Hi, everyone. Thank you for participating today in GlobalSkin and the ILDS's joint webinar, The Effects of Sunlight on the Skin and Public Education on Sun Protection, with guest speaker, Dr. Henry Lim. So if you've joined any of our previous webinars or workshops, you already know me. My name is Nicole Sidiaco, and I'm the Member Services Manager at GlobalSkin, and will be hosting today's webinar. For many dermatology patients, receiving clear information on sun protection is crucial in addressing the needs as a patient. So dermatology patients often have long-term and chronic health needs that would greatly benefit from up-to-date and relevant information on the effects of sunlight on the skin. And our guest speaker, Dr. Henry Lim, will share his knowledge today about the spectrum of sunlight, the effects of sunlight on the skin, and how to protect yourself from the effects of sunlight while enjoying your outdoor activities. So before we begin, I'm just going to go over the few logistical items. Number one, we encourage active participation from everyone. So I know people are joining from all over the world. Feel free to insert your name, your organization, and where you're joining us today in the chat box below. And this session will be recorded and shared with everyone afterwards. And also today's session will be about an hour long with Dr. Lim, who will take the first 35 minutes for the presentation, and then we'll have about 50 to 20 minutes for a group discussion. And then after the presentation, we will unmute participants and ask everyone to turn their videos on so we can address all your questions about sun protection, especially during these summer months. And then number 4, to maintain bandwidth, we'll be muting all microphones and videos of participants during the presentation. But feel free to message me in the chat box if you have any questions during the presentation. So finally, I would like to introduce Dr. Ramesh Bhatt from the ILDS, who will provide a brief presentation on our organization and the Patients Organization Working Group. Dr. Bhatt is a board member of the International League of Dermatological Societies and is also functioning as the International Director. And he is also the Vice Chair of the ILDS's Patients Organization Working Group. And he has 30 years of experience and is a member of several distinguished medical and dermatological groups at the international and national level. So without further delay, please take it away, Dr. Bhatt.
Thank you, Nicole. I'm audible now?
Yes.
Yeah. So I'm very glad to introduce, and I'm very proud to introduce International League of Dermatology Society, which represents 196 societies from more than 90 countries, representing over more than 20 million dermatologists. So our vision is to, of course, 2 lakh dermatologists. Our vision is to attain the best possible skin health for all people around the world. And our mission is to increase awareness, cooperation, and communication within the global dermatology community to promote high quality education, clinical care, research, and innovation that will improve skin health globally. Next slide. So our 2020-2023 goal is to strengthen and improve access to skin health around the world through partnerships. That is through strategic leadership and policy impact, representation and engagement, fostering access to dermatological education and care. In fact, we are mainly involved in dialogues with the World Health Organization also. We also have frequent meetings with the patient organization groups, and also we want to have impact on various government organizations all over the world, and we also educate dermatologists all over the world. Next slide. So one of the ILDS objectives for 2020-2023 to develop a framework for meaningful and systematic engagement and collaboration between ILDS and patient organization and patient leaders. ILDS Patient Organization Working Group goals is to ensure that the patient's voice is considered in ILDS activities and to foster dialogue and partnerships with patient organization to improve access to dermatological patient-centered healthcare worldwide. For more information on the ILDS and patient organization working group, we have Somana Achadu. You can contact him. and then more information is available in our website. So our main 3 ideas are, one is fostering exchange, and second one is building strategic alliances, and the third one is nurturing and supporting patient engagement. Next slide.
I believe that's the end of the slides, Dr.
Yeah.
Thank you so much.
Thank you, Nicole. So as of now, Professor Luca Buradori is heading the ILDS and patient organization working group collaboration, and I am the vice chair for that. So today we have with us Professor Henry Lim. So he will be talking mainly about the effect of sunlight on the skin. So I'm very happy to introduce Professor Henry Lim, and I know him for the last now nearly 5 years. So he's the former Clarence S. Livinghood Chair and Chairman of the Department of Dermatology, Henry Ford Hospital, and current Senior Vice President of Academic Affairs, Henry Ford Health System, Detroit, Michigan, USA. He received his MD from Sunny Downstate Health Sciences University, Brooklyn, New York, USA, and completed his dermatology residency at New York University School of Medicine. Dr. Lim has served as president of the American Academy of Dermatology, and I had the privilege of meeting him when he was the president of American Academy of Dermatology. Then American Board of Dermatology, American Dermatological Association, American Society for Photobiology, then International Union of Photobiology, and National Council on Skin Cancer Prevention. So in 2019, he was elected as a board member of the International League of Dermatology Societies. So I also got elected during the same time in Milan. So he has received multiple residential citations from the American Academy of Dermatology. And in 2020, he was awarded an honorary membership of American Academy of Dermatology. He has been recognized with the Fred W. Whitehouse MD Distinguished Career Award of the Henry Ford Medical Group, then European Academy of Dermatology and Venereology International Scientific Achievement Award. I think that award was given in Paris, if I am not wrong, in the year 2017. And I was also a witness for that function. So it was given by then the EADV president, Luca Buradori. And I was also there during that event. Then he has also received International Scientific Achievement Award, and then ILDS Society Certificate of Appreciation for International Leadership. Then Finsen Medal from the International Union of Photobiology, Alumni Achievement Award for Distinguished Service to American Medicine, College of Medicine, Sunny Downstate. So he is the honorary member of following international dermatological societies in Austria, France, Philippines, China, the Baltics, Spain, Taiwan, and Peru. He has published more than 570 articles, edited 11 textbooks, and served on editorial boards of several journals. So in my interaction with Professor Henry Lim, I have found out that he is one of the best dermatologists the world has produced. And he is a very good human being. And in fact, if you talk to him for 30 minutes, you will learn his depth of knowledge in the field of dermatology. And more than anything else, he is a great human being. Over to you, Professor Henry Lim, for your talk on effect of sunlight on dermatological disorders and what it does for even healthy individuals. Over to you, Professor Henry Lim.
Thank you very much, Dr. Bob. My mother would have been very proud to hear that. But that was a very, very nice introduction that you gave, and it's really very humbling. What I'm going to do, first of all, I would like to thank the organization for inviting me to participate in the session today. It's definitely a privilege for me to speak to leaders and members of patient organizations, which have been very much involved within ILDS, and other healthcare professionals who are participating in the conference. So if I may, I'm going to share my screen and my slide. And all right, can you all see my slides?
Yes, we can. Thank you.
Okay. All right. So the topic that I've been asked to speak about by Luca and Ramesh is on the effect of sunlight on the skin, as well as the public education for all of us on sun protection. The next two slides are my disclosure slides. With my interests, I have collaborated and worked as a consultant as well as a researcher for several of the photobiologic companies, primarily on those who manufacture sunscreens. So when we talk about photoprotection, we are talking about the effect of sunlight. This is a picture of solar eclipse that appears in National Geographic as a cover a few years ago, and the effect of sunlight, obviously, on the skin. So I will go over that, and the objectives of this particular session would be to recognize the short-term as well as the long-term effects of sunlight on the skin, and also to understand the appropriate way of protection of skin from these effects. So these are the four topics that I'd like to cover in the next, say, 35 minutes or so on basic principles, the acute, meaning short-term effects, the chronic or long-term effects, and lastly, the photoprotective means that we can do to protect our skin. So let's start with basic principles. So when we talk about sunlight, I think we have to talk about the spectrum of sunlight reaching the surface of the Earth. This particular graph, can you see my pointers, by the way?
Yeah, we can, yeah.
Okay, good. So this particular graph on the horizontal axis is the wavelength, and the vertical axis is the intensity of sunlight. You could see that the most studied one is the UV spectrum. The UV spectrum is between 280 to 400 nanometers. If you read textbooks, if you read any literature, most of the effects are discussed that have been discussed is on the ultraviolet light. However, we should notice also that visible light, which is the spectrum of 400 to 700 nanometers, is about 50% of the sunlight that would reach the surface of the Earth. We all know that we need visible light for life in general. You know, it is for general illumination purposes, for us to be able to see things around us. So it is an important component for life, but also new information now to show that visible light also has effect on the skin, has photobiological effect on the skin. So this is what is known about sunlight, specifically on the UV. By convention, UV is divided by wavelength into UVC, which is 200 to 290 nanometer, UVB, and UVA. Notice that UVC does not reach the surface of the Earth because it's completely filtered by the atmosphere. Therefore, it is not clinically relevant. The most clinically relevant spectrum of UV would be ultraviolet B, which is responsible for sunburn. And if you go outside, get sunburn, that is because of the UVB. It does contribute very significantly to skin cancer. In dermatology, we use it also for treatments for so-called UVB phototherapy, that is using the UVB. UVA, on the other hand, which is the longest spectrum from 320 to 400 nanometer, this is responsible primarily for tanning, for the wrinkling that one can get from excessive sun exposure for a long period of time, contributes to the development of skin cancer together with UVB. And then for allergic reaction to medications, the vast majority, over 95%, is because of the UVA. We also, similar to UVB, we use UVA for various types of treatments that we use to treat various skin diseases. And so To summarize, in terms of UV radiation, the easy way to remember is that UVB is the burning ray, the B is burning ray, UVA, the A is the tanning, and the aging ray, which is responsible for wrinkle formation. The other part that we should recognize is that this is just a basic concept in physics, that the shorter the wavelength, the less penetrating it is, the longer the wavelength, the deeper the penetration. And that's the reason that you can see here, the UVB penetrate up to the superficial part of the skin, while UVA penetrates a bit deeper. That has clinical relevance because, for example, for diseases involving primarily the superficial part, in terms of the treatment, we can use UVB, but for diseases involving the deeper part of the skin, then it is more effective to treat with UVA light for those conditions. Let's now talk about the long-term and short-term effects of the ultraviolet light. Let's start with the short-term effect. When we talk about ultraviolet light, we all most familiar with the redness, the sunburn reaction that can occur, but actually ultraviolet light can also induce pigment darkening, tanning, thickening of the skin, hyperplasia, and vitamin D synthesis. I will go over for you each one of these. The most familiar one is erythema. This is well known to all of us. In fact, if you go to Amsterdam, you can see this beautiful painting, a very small painting by Vermeer. You could see that if you look at this kitchen maid, she's pouring milk and so on, and he is very, very realistic painter. You can see if you focus on the arm, you could see the redness on the exposed area of the skin as compared to protected area of the skin. You can well imagine, when she go outside, she would bring down her sleeve, but this area of the forearm is still exposed. That's the reason this area of the forearm is more red as compared to the upper part of the forearm. And clearly, clinically, we all recognize this. This is 24 hours upon sun exposure on the top. Is a patient of mine who went out to mow his lawn on a sunny day, and clearly he got sunburned. And this is another person who gets sunburned. And then 4 days later, not only the redness is it's beginning to fade away, but beginning to get the tanning response that one can get. So another effect of the UV is pigment darkening. This is less appreciated probably by the general public, but there are two types of pigment darkening, immediate as well as persistent pigment darkening. Both are induced primarily by the longer wavelength UV, which is the UVA and also visible light. And then immediate pigment darkening occurs within minutes and it disappears within 10 to 20 minutes. So most of us don't even recognize it. Clearly, we can reproduce it and study it in the laboratory setting. The persistent pigment darkening take over after these 20 minutes. It persists for 2 to 24 hours. Again, most of us may not recognize that because it is not very prominent, but nonetheless, it is used, for example, for assessment of the protective property of sunlight, of a protective property of a sunscreen against UVA. This is one of the methods that is used to assess that protective property. Both of these reactions is caused by oxidation of pre-existing melanin. Therefore, there is no new melanin formation on the skin with IPD and PPD. What is associated with new melanin formation is tanning response. And this is the one that we are also very familiar with. Clearly, one can get very significant tanning with sun exposure, has been going on, has been used by many to get a suntan, and this is exactly what is going on. Keeping in mind any type of sun tanning, it is a reflection of damage on the skin. It is a reflection of the skin trying to protect itself by getting tan, so that would be less damaging ray would reach the surface of the, would reach the inner part of the skin. The other part that is not as noticeable, but I'll show you a picture of it that is that makes you would illustrate this, is thickening of the skin. Because if you look at area that has been exposed to skin repeatedly, a lot of time the skin is rougher and thicker, and this is because of what we call hyperplasia or skin thickening. And this occurs usually within hours to days. In the beginning, it could be subtle, but with repeated exposure, it would become quite noticeable. And again, this is a protective mechanism of our skin because by thickening of the skin, it would result in only mild photoprotective effect. The other one that is probably well known to all of us is the vitamin D synthesis. And then this is the pathway of vitamin D synthesis, starting from the skin here all the way down to the kidneys. But essentially the important part, the wavelength, is in the UVA or the sunburn spectrum of sunlight. So let me go over now the long-term. Those are all the short-term effect. Now let's go over the long-term effect of sunlight. And this would include the freckles that we all recognize. These are all on the sun exposed area of the skin. All skin types can be involved, but it's definitely much more noticeable in lighter skin types individuals. And this is another patient. You can see in the back here that this area obviously is more exposed to sunlight as compared to the lower part of the trunk. This is a very typical photoaging changes, that is wrinkling formation. Notice this is a 70-year-old lady, but you can recognize, you can imagine that this lady throughout her life probably has gotten a lot of sun exposure on the face. This is the side of the face, is her eye here, the side of the face. Notice how thick the skin is, how rough the skin is. If you can well imagine, if you touch it, you can feel the roughness of the skin. Sometimes people get it on the back of the neck for those who are exposed, working outdoor, for example, for a long period of time. This is very typical changes of photoaging of the skin. This is related to pigmentation of the skin. This is a very fair skin lady, 75-year-old. Notice that in darker skin individual, 83-year-old Asian man on the left, 79-year-old and 93-year-old African-American ladies. You can see, even though they are chronologically older than the lady that I have just shown you, the effect of the sunlight in terms of wrinkling is very, very minimal. You can see this 93-year-old is you barely could see the type of changes that you saw on the 73-year-old. This 83-year-old, for example, spent the vast majority of his early part of his life after about the age of 60 or so in the tropics, and yet you could see there is very minimal wrinkling of the skin noted. This is very clearly shown here in fraternal twins. The one on the left, obviously, being primarily indoor. The one on the right, obviously, spent a lot of time outdoor. You could see the significant difference in terms of the photoaging changes, even though chronologically the age is obviously only a few minutes apart. So in terms of the photoaging, this is another illustration. We do know that I mentioned before that photoaging UVA is an important factor on it. And then we also know that UVA is transmitted by glass, but UVB is not. But the longer spectrum UVA being more penetrating, it does get transmitted by glass. And this is a very well-known picture. Some of you probably have seen this picture before. It was initially published in New England Journal of Medicine, but have subsequently picked up by many late publications. This is a truck driver for 28 years, and he lives in Chicago. He usually drives around delivering milk. A delivery truck. You can see that the left side, obviously in the US, we write on the left side on the street. So the left side of the skin is significantly more photoaged as compared to the right side, because this is an area that gets significantly more sun exposure, even though through window glass. Again, UVA showing the effect of UVA on photoaging. A very well-known aspect of photoage sunlight is the development of skin cancer with long-term exposure. There's squamous cell, basal cell, and melanoma. These are three main cancers. All of them related to exposure from sunlight and also from indoor tanning lamps. Squamous cell carcinoma usually associated with long-term sun exposure, the use of tanning beds, and this is a clinical picture of it, usually a bump on the skin that is quite rough. You can see it on the lip here, always on the lower lip, because that is the area that get hit by sunlight much more so than the upper lip. And then basal cell carcinoma is more associated with intermittent sun exposure. This is shown here, usually is a bump on the skin, but tends to be much more translucent. And if one looks very closely and carefully, there's usually dilatation of the blood vessels. We call it telangiectasia on the skin. This is the most common appearance in fair skin individual, but in dark skin individual, one can get also pigmented basal cell carcinoma, as you can see here. The other one, which is the one of the more deadly forms of skin cancer, is melanoma. It is probably associated with intermittent sun exposure. The association is not as linear as it is with squamous cell carcinoma or basal cell carcinoma. Definitely, this has been associated with the use of tanning beds. And this is melanoma. Essentially, it looks like a mole, but very atypical looking, usually darker, rapidly expanding. You can see the central clearing here, which is unusual for any type of moles. You can see at the edge here, it is not very, very sharp in terms of the periphery. Likewise, over here, you can see the variation in color. These are pictures of melanoma. So this is something that has to be taken care of immediately. This is another patient. I just want to highlight that melanoma can occur on the toe, or on a nail, essentially. So if you have dark streak like this on a nail, it is definitely important to have a dermatologist to take a look at that to make sure that it is not a melanoma. So this would bring them to the subject of photoprotection. How do we protect ourselves against the effect of all this sunlight? I want to highlight that for photoprotection, it is important that, for us as physician, and when I give lectures to my fellow dermatologists, I always ask the dermatologist, we should continue to encourage patients to go outdoor, because there are a lot of outdoor benefits from outdoor activities. We all enjoy going outdoors, so we should not prevent them from going outdoor. However, what we can advise patients, what can advise the public, is that to practice appropriate photoprotection. And this is the whole package here. That is, to stay in the shade when outdoor, if possible, to wear the appropriate clothing. There are a lot of photoprotective clothing available now. They're very thin and yet very tightly weaved. Because of that, they protect the skin without causing too much sweatiness underneath the skin, or too much heat underneath the skin that would build up. And then to wear wide brim hat to help to protect the face and the head, especially important for men, who is a lot of men starting to get bald on the top, and sometimes they forget to protect that area. So hat is very, very important. Wearing sunglasses obviously is important to protect the eyes and the skin around the eyes. And sunscreens is an important component, but it's not the only component of photoprotection. Sunscreen should be used only on the exposed area of the skin that is not protected by clothing, by hat and sunglasses. What is the effect of sunscreen on skin cancer? This has been studied very well. This is probably the best studied, a total of 4.5 year plus 8-year follow-up studies, or 12-year study of 1,600 individuals from Australia. Clearly, these are a lot of the patients of fair-skinned individuals there, get a lot of sun exposure. What was found is that regular use of sunscreen resulted in a decrease in the squamous cell carcinoma by 38%, which was statistically significant in this study. The basal cell carcinoma also decreased by 25%, even though this is a big number, but statistically was not significant. It is probably because the number of patients, even though 1,600 is a good number, probably is not large enough for statistical analysis to reach a significant level. But nonetheless, you can see a very strong trend here. And also the authors showed that there is a decrease in the development of melanoma. Clearly, melanoma is hard to get statistical significance because it's much less common compared to squamous cell and basal cell. So it's very hard to get a large number to reach statistical significance. But nonetheless, this is very, very strong evidence to show that the use of sunscreen is very helpful. Let me outline for you in terms of the sunscreen. Sunscreen generally is classified into two general categories in terms of the active ingredients of the filters. One is organic, also known as chemical filters. That would be some of them are designed to cover ultraviolet B. Some of them are designed to cover ultraviolet A. Some of them are designed to cover both. But the important part with organic or chemical filters, all of them, they protect against UVB or UVA by absorbing the UV radiation. So they essentially, like a sponge, they absorb the UV photons. Because of that, it protects the skin. Not 100%, but they are quite well. I mentioned sunscreen has two ingredients. One is organic ingredients. The other one is inorganic ingredients, also known as mineral filters. So mineral filters, there are only two: titanium dioxide and zinc oxide. So in many sunscreen products, it is a combination of chemical as well as mineral filters that we put together. However, there are quite a number of sunscreen products that contain only mineral filters, only titanium dioxide or zinc oxide as a filters. Important part also, the mechanism of organic filters is a bit different. It does reflect and scatter, but also in smaller particle, it does absorb UV radiation. So it has a different mechanism as compared to organic filters, which truly only absorb UV radiation. And I mentioned before that sunlight induces synthesis of vitamin D. So a lot of questions that have been asked of us is that would it affect our vitamin D level? Would it result in vitamin D deficiency? So this is an article that was published in 2019, an expert opinion based on review of the literature. And what the conclusion is that sunscreen used for daily and recreational photoprotection does not compromise vitamin D synthesis. Again, this is a collective opinion of the experts after reviewing the literature. And the reason this is the case, does not compromise vitamin D synthesis, because we do know that when we all use sunscreen, we use it less than what is required by the regulatory agency in the US, is the FDA, to test the sunscreen. Sunscreen is tested at 2 milligrams per centimeter square based on FDA requirement. We use it usually between 0.5 to 1 milligram per centimeter square. So automatically the in-use SPF is lower than the label SPF. However, the second bullet here, rigorous photoprotection, that is, wearing photoprotective clothing, shade, and sunscreen is likely to compromise vitamin D synthesis. So in those patients, we do recommend for them to take vitamin D supplement. One multivitamin a day should be sufficient, because at least in the US, it contains enough vitamin D to supplement you to a sufficient level. The other part is visible light. This is a newer information. What has been found is that our group is one of the leading groups in doing this. Visible light together with a small amount of long-wave UVA would induce pigmentation. This can be seen here on the left side. You could see this little dot here. This is pigmentation secondary to exposure to visible light, which persisted for quite a while. And notice that this is only in darker skin. In light skin individual, when the same study was performed, there was no alteration of the pigmentation, therefore indicating that visible light, especially in dark skin individual, is a very important contributory factor for pigmentary alteration that can occur very frequently in dark skin individual. So in terms of sunscreen protection, I've mentioned that sunscreen protect against UVB and UVA, which is, but it does not protect against the longer wavelength UVA, nor against visible light, because realistically, in order to protect against visible light, the sunscreen would have to be visible, meaning it has to be visible to the naked eyes, because that is how we can tell that there is a substance in there, because the visible light would get reflected by that substance, by that agent, and it would be perceived by our retina as something that is on the skin. So at this moment, at least in the US, I know in Canada also, only tinted sunscreen would protect against visible light. A tinted sunscreen contain iron oxide and pigmentary titanium dioxide. All of them contain iron oxide. Some of them contain pigmentary titanium dioxide. In Europe, there are two UV filters, two new filters that would protect against the long wave UVA, and also one of them would protect against visible light. But those filters are not yet available in Canada, in the US, and I think for most part of the world. Definitely in Europe, they are available. So lastly, then, how do we advise patients and the public knowing all this information? One, I think it is very important for all of us to recognize that the adverse effects of sun exposure are very, very well established. This is beyond doubt. The science is very, very strong on that. So this is something that we need to convey to the public, to for those healthcare professionals, to our patients. I mentioned before that practice of photoprotection is essential. People should continue to be encouraged to go outdoor, participate in outdoor activities if they want to do that, but they need to do this package here of seeking shade when outdoor, wearing photoprotective clothing, white brim hat, as well as sunglasses, and applying sunscreen on the otherwise exposed area. Usually we do recommend an SPF 30 or above, broad spectrum, because this would indicate that particular sunscreen would protect not only against UVB, but also against UVA, and then tinted sunscreen to protect against visible light. This is especially important for darker skinned individuals. Clearly, I don't have time to go over the environmental effect in terms of controversies on these, but for those who are concerned about the environmental effects of sunscreen ingredients, especially oxybenzone and octinoxate, these are the two that have been sort of published the most, then just go ahead and use the mineral or inorganic sunscreen, which is titanium dioxide and zinc oxide only sunscreen. And as I've mentioned before, with the practice of rigorous photoprotection, then vitamin D supplement daily would be appropriate. Lastly, I want to highlight the need of individualizing and tailoring the sunscreen recommendation or photoprotection recommendation for different skin types, especially speaking to this audience. It is a very global, and clearly in US and Canada and Europe, we see a lot of different skin types of patients. This table, which is from an article that we published in 2021, this is the typical classification of skin in dermatology using Fitzpatrick skin type from skin type 1 to skin type 6. This corresponds to the skin color from very light, very fair skin individual to very dark skin individual. What I want to highlight is the one in the red here. That UVB protection factor, which is reflected by by the SPF, which is sun protection factor. We know that fair skin individual get sunburned more commonly compared to dark skin individual. So we can recommend higher SPF for lighter skin individual, but for darker skin individual, we can recommend lower SPF of 30 plus rather than 50 plus, because they get sunburned less likely. Not the probability is not zero, but it is less likely. In terms of UVA protection, the light skin requires a little bit less of the UVA protection. The darker skin individual, because of the discoloration that can occur, and UVA is an important contributor to that, then we need to recommend a higher UVA protection factor sunscreen for these individuals. Lastly, in terms of the visible light protection, I've mentioned to you before that for darker skin individual, it is important to protect them against the effect of visible light to prevent the discoloration that can occur in the skin. It is less so for light skin individual. Clearly, having said all this, what is the best way to protect our skin in the sun, from the sun? This is a very beautiful picture by Vincent van Gogh, which is in Musée d'Orsay in Paris. You could see that this is the best way to protect against the sunlight, obviously, to go out only at night. Clearly, this is not acceptable to all of us, not acceptable to our patients, not acceptable to the public, and not acceptable to all the healthcare providers. But then if you look back as far as the 1800s here, George Seurat already had painted very, very nice picture in Chicago. This is in Art Institute of Chicago, how to protect against the sunlight. Staying in the shade, as can be seen here, wearing the appropriate clothing, carrying parasol. Nowadays, at least in Western country, this is not commonly done, but in Eastern country and Southeast Asia, for example, it's very commonly done, people to carry parasol, wear hat and sunglasses. Obviously, in 2022, we need to make sure that people use sunscreen on the exposed area of the skin. So with that, I'd like to thank you all. Just want to highlight that, one of the important function of ILDS that Dr. Bhatt had already outlined is also to organize every 4 years World Congress of Dermatology. We are actively organizing this for in-person meeting in Singapore in 2023. This is an in-person meeting. There are quite a bit of patient input, also input from patient organization in the program. So there are a number of patient-related programs in this particular session. The scientific program is very robust, and we are finalizing the program. Thank you all again very, very much.
Thank you so much, Dr. Lim. That was an incredible presentation, and I thank you so much for taking the time to provide our patient leaders this really valuable information. So now I invite everyone to turn on your cameras just so we can see everyone's lovely faces. Yeah, I know that there's already one question in the chat box from Yalchin Mamadov, who is also GlobalSkin Europe strategic advisor. So Yalchin, feel free to turn on your camera and ask the question if you'd like, or I can go ahead and ask it to Dr. Lim.
I can read it, but essentially the question is that for patients with psoriasis, and for that matter, actually patient with atopic dermatitis or eczema, sunlight is known to be helpful. In fact, we do use it in the clinic, in the office. Phototherapy, for example, one of the major indications for phototherapy using ultraviolet light to treat the skin disease is psoriasis. So definitely we do know psoriasis respond well to ultraviolet light treatment. So the question is that how do we connect this with photoprotection, with going outside and so on and so forth. The advantage of phototherapy, obviously, is that it is very controlled. We know exactly the dose that we deliver. We know if the patient turns red to decrease the dose and so on and so forth. So it's very closely monitored type of sun exposure, quite closely controlled sun exposure. But limitation of phototherapy is that not all patients would have access to phototherapy unit because it's quite far, it would not be, may not be in their community. So a practical answer that I give usually to patients, if they have no access to phototherapy unit, and if I feel that they can benefit from UV exposure, I tell them, especially in the summertime, in Michigan, we cannot do it in the winter, but in summertime, if they want to expose the area to sunlight, is perfectly fine to do that. In Michigan, for lighter skin individual, 20 minutes of sun exposure midday between 10 to 2, which is where the peak of the UVB is the strongest, is the appropriate time. So I tell them to expose themselves and then start maybe with 15 minutes and increase by a few minutes each time up to 20 to 25 minutes and stay at that. That can be definitely done, but I would advise them not to continue beyond that because you can get potentially sunburned. Hopefully that answered the question.
Thank you, Dr. Lim. We have another question. Go ahead, Yalchin.
Turn on my camera. Sorry, Dr. Lim.
Sure. You have another question?
Maybe we'll, Yalchin, did you have another question?
No, I don't have any other question. Thank you.
Okay.
Thank you, Antoine. Oh, sorry, thank you, Yalchin. We have another question from Antoine. So with the increased access to broad spectrum high SPF sunscreen, persons with albinism can be tempted to spend more time in the sun and enjoy outdoor activities. Is this risky, given the effect of visible light on the skin and the fact that the UVA spectrum is not yet fully covered by sunscreen? Persons with albinism usually don't have tinted sunscreen as it would give them a strange appearance.
It is a very, very relevant and important question. And unfortunately, we don't have the full data on this part yet. But clearly with patients with albinism, they do get sunburned very easily. So photoprotection in general, including the use of sunscreen, high SPF sunscreen, broad spectrum on the exposed skin is very, very important. The effect of visible light has not been completely fully studied in terms of skin cancer. So right now, I cannot give you a clear answer as to whether visible light would contribute to the development of skin cancer. Definitely, we have information on UVB, we have information on UVA, but we don't have information on visible light. So I cannot answer that part of the question because the data is not quite there yet. Now, your other question is about the long wave UVA, which is the wave, the part of the UVA that is closer to the visible light spectrum, closer to 400. Usually we talk about 370 to 400 nanometers. It is absolutely correct that the regular sunscreen, except for the one that contains the 2 filters in Europe, they don't protect against the long wave UVA very much. But again, that very narrow spectrum of long wave UVA, how much they contribute to skin cancer right now, we don't have that full information as yet. So I think this is an area that we need to continue to evaluate and discuss. The tinted sunscreen would give a strange appearance. On the other hand, the fact that patients with albinism of your skin is very white. So theoretically, one could use not tinted sunscreen, but sunscreen that contain pigmentary titanium dioxide or pigmentary zinc oxide. These are sunscreen that contain larger particles of zinc oxide and titanium dioxide. That would result in a whitish, but not tinted, but whitish appearance of the skin, which obviously for for patients without albinism, it is more difficult to be used because aesthetically it's not as pleasing. It's a very good question that a lot of information gaps still there.
Thank you, Antoine, for the question. Thank you, Dr. Lim, for your answer. We have another question from Rebecca Strong from the International Pemphigus and Pemphigoid Foundation. Rebecca, feel free to ask your question yourself if you'd like, or I'm happy to read it aloud.
Hi, Dr. Lim. Nice to see you again.
Nice seeing you.
My question is, what is the safest way to apply sunscreen for those of us who have open lesions or blisters on our skin?
Good question. My answer is that not to apply it directly on the opened area. Probably either use a physical cover-up, that is to use Band-Aid and so on, and then wait until the skin heals. Primarily because the effect of sunlight is starting on the surface of the skin in terms of tanning, in terms of blisters, and so on and so forth. If the skin is already open, presumably the epidermis is not quite there, so only the dermis, and we don't want the sunscreen to get completely absorbed into that area, especially if the pemphigus is or pemphigoid is quite extensive. For example, you don't want all these chemical filters to be absorbed into the system. We want to minimize that. So I would not advise on an open area to be used.
And then what about for blisters that are still intact, that haven't ruptured yet?
Again, likewise, I think to apply, especially in pemphigus, obviously the blister is very fragile, but in pemphigoid, it could be tense blister. One can apply carefully, but again, it's probably going to be hard because by the time you try to rub sunscreen there, it may break the blister. So my suggestion is probably physical protection, meaning Band-Aid clothing would be more practical for that.
Great, thank you so much.
Sure.
Thanks, Rebecca, for the question. We have another question from Lexi. Lexi, I don't know if you'd like to turn on your camera and ask the question yourself.
Sure. Just pertaining to Yelchin's question about treating psoriasis with natural UV rays, is that with sun protection like a sunscreen or without?
The answer is that without sunscreen, because if you put sunscreen on, you're blocking the UVB. You want, for the scenario that I have just mentioned, 10 minutes to 20 minutes of sun exposure 3 times a week type of thing to replace phototherapy in the office or in the clinic, you want to get UVB to get into the skin. So you put sunscreen on, the amount of UVB is going to be minimal.
Got it.
So without sunscreen.
Henry, after the exposure, we advise them to apply the sunscreen.
I would ask them to go indoor or to apply sunscreen, to apply clothing, to practice the rest of the photo protection package that I have just mentioned. Yes, absolutely. Thank you for reminding me.
Thank you. So we have another question from Joseph from Rwanda, the Anti-Vitiligo Rwanda Foundation. Joseph, feel free to ask the question. Oh, I think he's still there. So if you'd like to ask the question yourself to Dr. Lim, feel free to go ahead. Otherwise, I can. So he's turned off his camera and is muted, so maybe I'll ask it. Do you mind clarifying, I guess, the similarity or the relationship between vitiligo and skin cancer?
Vitiligo being the lack of melanin on the skin, the lack of melanocytes on the skin, definitely is more prone, especially on those areas, more prone to development of skin cancer. So definitely, I think photo protection in general for patients with vitiligo is very important because we do know that the area with vitiligo, there is really no photo protection capability of the skin. So photo protection is important.
Thank you, Dr. Lim. We have another question from Antoine. So normally it's recommended to reapply sunscreen every 2 hours. However, a few sunscreens available on the market claim to protect for a longer period. One is even called day long. So what is your opinion on this?
It's a very good question and very practical question. The recommendation of sunscreen to be applied every 2 hours applies only for when patient goes outdoor, has a lot of sweating, come into contact with water. That is, I think, as the dermatologist, I always tell my colleagues when I give lectures on photoprotection, is that your advice to patient would have to be practical, because otherwise no one is going to follow your advice. So usually, what I say is that if it is outdoor, if you're going to be outdoor, you're going to be coming into contact with water and sweating and so on and so forth, you do need to reapply the sunscreen every 2 hours, or even more frequent if necessary. If you go swimming, for example, you do have to apply sunscreen more frequently. On the other hand, if you're primarily indoor and then just go outside to go to grocery store or what have you, it is not practical to ask people to use sunscreen every 2 hours. It's not practical, nor is it necessary. So the claim of the sunscreen being day long, for example, is because this is probably about 10 years ago. There are some sunscreen ingredients, specifically avobenzone, is known to be very photolabile, meaning that if you expose this chemical to sunlight, it would degrade, it would lose the ability to protect against UV. However, that had been overcome completely. Now all the avobenzone containing filters, they have been made in such a way, either with other UV filters or with other agents that would photostabilize the avobenzone. So it's no longer photolabile. That is the reason that for marketing purposes, sometimes they say, well, it is a day-long photoprotection. It is definitely not correct. I don't advise that, because especially if you're doing outdoor activities, not only the sweating and the water, but even the normal walking and all that, if you do a lot of physical activities, one of the reasons sunscreen would have to be reapplied is that it gets rubbed off, right? You walk around, you do activities, some of the areas would get rubbed off, so that has to be, those areas would have to reapply. So that one is a common judgment, but I think to say the sunscreen would last all day is not quite correct. It's different than if it is applying on the face, working primarily indoor, in the office, for example, pre-COVID, at least, many of us go to the office and then just go outside to the car to drive someplace. That, to me, once a day sunscreen should be sufficient.
Thank you, Ifan, for the question, and thank you, Dr. Lim, for your answer. I actually have a personal question as well regarding topical steroids. So can you comment on the reaction of the sun and topical medications on the skin, and also applying sunscreen while already wearing topical medication?
When one gets sunburn, indeed, one of the quickest way, if it is severe enough, one of the quickest way to control it is either using topical corticosteroid, or if need be, systemic, that is oral corticosteroid. Both of them very strong anti-inflammatory agents would help to bring it down. So usually, if patients with sunburn, if it's not too severe, I tell them to use the topical corticosteroid probably for 3-4 days or so, just to bring down the inflammation, to make the patient more comfortable. If it is severe enough, if it is very widespread, oral corticosteroids for 5 to 7 days will be sufficient also to bring down the inflammation. Usually I just give them a course without any taper. We just stop it after 5 to 7 days. You don't have to taper down, and that should be sufficient to bring down the inflammation, to make the patient be more comfortable. The other part, your question is about layering. Essentially, if you use medicine, you use makeup, how do you layer all this medication? The principle is that when one use medication, you want the medicine to come into contact with the skin. So if you use acne medication, you use topical steroids on the face for whatever reasons, for example, I would use the prescription medication first, then apply the sunscreen after.
Thank you, Dr. Lim. So are there any more questions for Dr. Lim regarding his presentation or in general? Yes, thank you, Dr. Lim, for an excellent presentation. I also just want to comment that I appreciate the example specifically of skin of color in comparison to lighter skin. I think oftentimes those examples are not shown, so I appreciated that. Antoine actually has one more question. If someone does not display any sunburn after having spent a full day in the sun, using sunscreen on the exposed areas of the skin, does this mean that no long-term damage was done to the skin?
Depending on what it is, if there is it is using sunscreen or to the extent, practicing photoprotection, but using sunscreen to the extent that there is no visible redness, there's no visible tanning, then that means that the damage is very, very minimal. Probably microscopically there will be some, but clinically, and realistically in practice is very well photoprotected. And this you can see, at least we see them all the time, that for patients who work primarily indoor, compared to patients who work primarily outdoors, when they're 70-year-old, the skin is very, very different. So yes, the answer is that with good photoprotection, there'll be significantly less damage. Is it zero? It's hard to prove, but it is probably closer to zero.
We have another question from Joseph. Do you advise or recommend frequent or regular UV treatment for vitiligo? Are there no side effects?
Yeah, UV treatment, as you know, as the question implied, is a standard treatment for patients with vitiligo. There are two types of UV treatment. One is with extensive vitiligo, we use the total body UVB booth usually. And then for patients with localized lesion, if one has access to it, excimer laser works very well. Also, it's UVB wavelength is used. And it is used quite a bit, and it all around the world. Usually, the treatment we have a vitiligo center in our clinic, and we see a lot of vitiligo patients. So usually, we treat 3 times a week or twice a week to 3 times a week in the beginning. Keeping in mind that for the treatment of vitiligo, it requires a long treatment, 60 to 90 treatments per course. And then also keeping in mind that a lot of time it is not 100% repigmentation. So that should be recognized and should be informed. Patient need to be informed about that we can get a fairly good repigmentation, but probably not 100%. And usually once the response has plateaued off, I would then taper and eventually stop the UVB. And then down the road, if a year, 2 years later, if patients develop new lesions again, we can always reconsider the UV treatment. Properly done, it is quite safe, even though I mentioned before, there's obviously the risk of skin cancer, but it's one of these things that you have to balance the risk and benefit. And these patients with vitiligo, obviously, we see them on a regular basis. So in terms of monitoring, in terms of surveillance, is very, very strict here.
We have another question from Anne-Marie. Lupus patients often get the advice to go outside before 10 a.m. and then after 3 p.m. because of the UVA and UVB. What do you think? All the protection you mentioned is also advised. Yeah,
this is related to the UVA and UVB, as you mentioned, because during the midday, UVB is strongest. UVA is there, but UVB is much stronger because it is shorter wavelength, so it doesn't penetrate as deep during the morning and afternoon hours because the sun ray is reaching the Earth at an angle. So they have to go through a much longer path in the atmosphere before reaching the surface of the Earth. UVA, on the other hand, because it is longer, it does penetrate morning and afternoon. So as long as there's sunlight outside, there's always constant amount of UVA. So the answer is that specifically the sunscreen, broad spectrum sunscreen, needs to be used throughout the day, in addition to clothing and everything else.
Thank you. Are there any final questions before we end the webinar? If not, I'd like to provide a huge thank you again to Dr. Lim, the ILDS, Arpita, and Professor Bott for supporting in the coordination of today's webinar. It's been great. I'm very excited to share the recording with our patient leaders as well as the medical professionals in the ILDS. So thank you again for a wonderful presentation, and I hope you have a wonderful rest of the day wherever you are in the world, or evening or night wherever you are. So many, many thanks. Thank you.